through the votes. Just remember you can either say aye, abstain, or nay when we do the roll call voting. Also, if you could please mute your line when you're not speaking, but please don't mute mine. It's now happened twice. So I'm the FSSA video conference. It's very unhappy times when you mute us. We have to sign back in again. So if you could just mute your own, that would be fantastic. And I will defer to Dr. Ott as we move through the agenda. We do have a very full agenda today, as we often do in November, so we'll try and get through things as expediently as we can. So I will start with you, Dr. Ott, for the call to order.
Sure, so I'll go ahead and call this November 2023 meeting of the DUR Board to order.
Any remarks today?
None, thank you.
And next up, opening comments from OMPP.
None today, thanks.
All right, that takes us up to approval of the minutes.
There a motion to approve?
Move to approve, Dr. Marshall.
Second, Petra.
All right, we have a motion and a second. Dr. Ott.
Aye.
Dr. Klass.
Aye.
Ms. Phippen.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
All right, that carries as we have all approved. We carried over an agenda item from last time on the expiration of Dr. Shaw from the Therapeutics Committee. Did want to confirm he would be delighted to serve another term should you all wish to approve him. So I will turn it over to you, Dr. Ott.
Sure, do we have a motion to approve Dr. Shaw continuing on the T committee? Okay, now you're cutting me off.
Got a full agenda, Carol, full agenda.
Oh, you know, I moved. Trust me, I know. I'm going to move this along.
I'm trying to help. Never mind. All right.
If you guys are done, I'll second it.
All right, we have a motion and a second. Dr. Ott.
Aye.
Dr. Klass.
Aye.
Ms. Phippen.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
All right, that motion will carry and we will let him know that he has another term. All right, let's get started then in our PA stats and all of our other recommendations that we have for today. So for October, overall, we had 72% approved and 28% denied. And you could see the numbers there for the totals. Within silent auth, we had 74% approved and 26% denied. Of those that were denied, 23% went to the call center for further review, where 79% were approved and 21% were denied. And then we had an overall 53% approval and 47% denial in the manual PAs, on the manual PA side. So what I think is a little bit more helpful to look at is our trending graph. You can see pretty in line with where we've been. September was a little down and October's gone up a little bit. There's one more day in October, so sometimes just that one more day makes a difference in how many PAs we receive. When you look at the top 10 in the silent auth requests, we had stimulants in number 1, opiates and antipsychotics in the top 3, and so that's pretty much what we've been seeing in that group now for quite some time. In the manual PA requests, we had early refills, beta adrenergics and corticosteroids, and the MHQAC utilization edits. So you might have noticed that the beta adrenergics and corticosteroids jumped up a little bit this month. That's not uncommon that we see that happen during this time, especially when we get in the cold, flu, and potentially now COVID season, because it seems like we're having seasons for that now. So kind of what we would expect to see around this time of year. Any questions on any of those before I go into the opioid statistics? All right, so we did have just a slight increase from September of the total utilizers, but not a ton. And then we had an increase in the new opioid utilizers of just a little over 6.5%. We did have a pretty significant decrease of new utilizers in September, so I'm not surprised to kind of see it come back up again. You can see that our under 18 hanging around 4.5 days. So it's actually a little bit lower in the day supply because we had been hanging closer to 5 days. So around what we've been seeing there. When we look at our trending, so this is the 90 and above, you can see again, the vast majority of members are in less than 90, and then we've got smaller numbers in kind of the other groups. We are at 575 MME in the decrease right now, and so you'll notice that we're seeing kind of that 250 to 500 look a little bit higher in this graph, and that's as we would expect as we kind of start moving some people down and out of those other numbers. When you look at the overall trend, so in the, just as a reminder, in the greenish color at the bottom, that's the current utilizers greater than 18. New utilizers are in the cranberryish color, and then the less than 18 or less than or equal to 18 are in kind of that purpley blue color at the top. So you can see it did kind of come back up just slightly, but still a little bit lower maybe than what August was as far as new utilizers. So we still are seeing kind of that steady increase. One note, we haven't had a chance to fully evaluate this data yet, but I want to bring it up here as just an interesting point that Dr. Shaw brought up during the therapeutics committee meeting, which was he's seeing recently a lot of increased prescribing of opioid therapy out of the ER that he said previously had kind of gone down and now is kind of taking an upswing. So he's having patients come back to him that are having an increased prescribing from the ER. So he was speculating that maybe, you know, at one point that was tightened down a little bit. Now we maybe have some people going to the ER a little bit more to get payment. So that is something that we're going to try and take a look at to see if we're encountering the same thing and see what that data looks like, to see if there's something we need to potentially intervene on there or discuss as options. When we look at our overall trending, so in the less than 90 MME, you can see it continues to kind of rise. And again, we think this is related to most of our new starts are less than 90 or short-term therapies less than 90. So that's been increasing. And then in the other groups, we're seeing, you know, decreasing kind of over time. So the 90 to 120 has been overall kind of fairly steady, and now is decreasing a little bit. And then you can see again what we kind of talked about before, the 250 to 500s increasing on the graph, while as the higher numbers go down. So pretty much what we would expect to see here. And just a reminder, it's a very small patient population, so just changing a few people can really significantly change the graph. That being said, it's still kind of what I would expect to see based on what we're doing in the movement in this graph. Any questions on the opioid reporting? All right, so next up then we have the MHQAC updates and edits. So the utilization edit recommendations, there's a new product, Rakindo, which is a risperidone subcutaneous injection. It comes in at 25, 37.5, and 50 milligram strength. The recommendation is 2 per 28 days and age 18 years and older, which is consistent with all of our long-acting injectables. And then I'm going to go ahead and go through this next part, and then we can vote on it all at once. So just as kind of an FYI, because Rakindo is an antipsychotic, we do add it to the antipsychotic PA for duplicate therapy assessment. And then in the sedative hypnotic benzodiazepine PA, the Mental Health Quality Advisory Committee recommended adding chlordiazepoxide, clodinium, and clobazam to the historical look back for duplicate therapy. And then just a note on the clobazam for duplicate therapy, if they have a seizure diagnosis, that will bypass the edit. As we know, some people have rescue meds, rescue diazepam, rescue Ativan that they have on file for their seizure disorder, and they take clobazam regularly. Any questions or comments on any of those?
No, I assume you need a motion to approve?
I do, please.
Hi,
Looks like
Chris
Dr.
Johnson
Class.
here. Yeah, well, I'll second it if Dr. Class motion.
Okay. Amanda, it looks like
Perfect.
there's a motion to approve in a second.
Thank you. Dr. Ott.
Aye.
Dr. Class.
Aye.
Ms. Pippin.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
All right, we had all ayes, so that motion will carry. Thank you. All right, we've got therapeutics committee recommendations. So in the CNS and others recommendations, the therapeutics committee had no recommended changes in the gastroprotective agents. For the agents for the treatment of opioid use disorder or overdose, they're recommending that Brixadi maintain its current status of non-preferred and then add to the agents for the treatment of opioid use disorder PA criteria, which now has drug-specific PA criteria, maintain its current age limit, and then add a quantity limit. So there's quantity limits there for either the weekly dose, which is 8, 16, 24, 32, which is 1 injection per 6 days. And then for the monthly dose, the 64, 96, or 128, those are 1 injection per 28 days. For OpV, which is a new nalmefene nasal spray, they're recommending adding to preferred. And then Sublocade, the long-acting injectable, they're recommending moving to preferred and adding to the agents for the treatment of opioid use disorder PA criteria with drug-specific PA and maintaining its current quantity and age limits. For the antiemetic, anti-vertigo agents, they're recommending kind of a switch here between Bonjesta and Diclegis. So Bonjesta would move to non-preferred, maintaining its quantity limit, and then adding a max quantity limit of 270 days of therapy per 365. And then Diclegis would move to preferred and the preferred brand list. So this would be the brand on the preferred side, and then maintaining its current quantity limit with adding the max of 270 days of therapy per 365. For the anti-seizure agents, Solantin, they're recommending adding to the preferred brand drug list, and the preferred brands we are moving more effective sooner, so those would be moved 12-1. Methotrexamide, which is the generic, would move to non-preferred, and then it would have PA criteria around meeting the generically medically necessary PA. And then Montpellier XR, which is a long-acting lacosamide product, would be added to non-preferred. The immediate release product is preferred. Then for movement disorder agents, Austedo XR and the Austedo XR titration kit, moving to preferred and updating the PA criteria to remove the rationale for use of Austedo XR over Austedo immediate release. And then Ingrezza, maintaining its current status, but updating the PA criteria to include the chorea associated with Huntington's disease. And with that criteria, they should be 18 years of age or older. The max dose is 80 milligrams a day, and then it's 1 capsule per day on each of the strengths, so 40, 60, or 80. Trihexyphenidyl tablet in solution, adding to preferred, as well as the benztropine tablet in injection, adding to preferred. Historically, these have just been neutral, but we're trying to capture all the agents within this class to make sure it's complete. For the narcotic antitussive combinations, we did make an update to the PA criteria to have it make a little more sense on specific to narcotic antitussives versus just opioids in general. And so the updates that we put on there are for kind of the long-term use PA. So in the long-term use PA, if they're a current utilizer of narcotic antitussive therapy for 90 days of therapy in the past 120, they would be considered for long-term use, versus the way it's written right now is any opioid for 90 of 120 allows them to use long-acting narcotic antitussives, which doesn't really seem to match. So we wanted to update that. We're removing the sickle cell disease as an exclusionary diagnosis, and then updating the terminal diagnoses to other terminal diagnoses with concomitant intractable cough. And then we maintain the cancer and palliative care as exclusionary diagnoses, just because a lot of times we have like end-of-life COPD who are on these therapies long-term. For the hydrocodone hematropine tablets, maintaining its current status and current age limit, but adding a quantity limit of 36 tablets per prescription. And then for the promethazine BC codeine syrup, maintaining its status and age limit, but adding the quantity limit of 6 ounces per RX, just so we have quantity limits on all the products in the narcotic antitussives. All right, in the narcotics, again, you'll see some oldies in here that we're adding just to be complete. So belladonna opium suppository is not new, but bringing it onto the PDL just so we can capture it. So recommending adding to non-preferred and the non-preferred short-acting PA criteria and the short-acting look-back for duplicate therapy. Lortab elixir is no longer manufactured in CMS terms, so we're recommending removing that from the SUPDL. Methadone, we wanted to add a note to the public-facing criteria that methadone for opioid use disorder is not permissible reimbursement through the pharmacy benefit and needs to go through the medical benefit, so we just wanted to clarify that. For the methadone concentrated solution, maintaining its current status, but adding a quantity limit of 6 mils per day or 12 mils per day if they have an exclusionary diagnosis, and this is following in line kind of with the 60 MME or the 90 MMEs or 60 MMEs at the start, and making sure that we're capturing that since CDC updated their conversion factor. And then for the methadone 10 and tablets and the 10/5 solution, updating their quantity limits as well. So the 10/5 solution would be 60 mLs per day, and the methadone 10 milligram tablets would be 12 tabs per day. Opium tincture, also not a new one, but something that we're bringing onto the PDL, adding to preferred and the preferred short-acting PA criteria, as well as the short-acting look-back for duplicate opioid therapy. Oxycodone ibuprofen is no longer manufactured in CMS terms, so removing that from the SUPDL. And then Qdolo is no longer participating in the MDRP or rebate program, so removing that from the PDL. Siglentis, we're recommending adding a quantity limit of 4 tablets per day. And then the tramadol products, all except tramadol ER, and then the tapentadol products, except for the ER products, maintaining their current status, but updating their quantity limits for new short-term utilizers to ensure that they're not exceeding the 60 morphine milligram equivalent, since their conversion factor was also updated by the CDC. And then maintain quantity limits as they're currently established for chronic or long-term utilizers. And the skeletal muscle relaxants, orphenadrine, aspirin, caffeine, adding to non-preferred. In the smoking deterrent agents, Chantix, the brand name, is no longer manufactured in CMS terms, so we're recommending removing that from the SUPDL. The generic is still available. The Nica Relief gum, we're recommending removing from the PDL as they are no longer manufactured in the MDRP. And then for the non-preferred nicotine replacement products, we wanted to add some quantity limits and age limits like we have for the preferred products. So the Nicotrol NS nasal spray would be a quantity limit of 12 bottles per 30 days, age 10 years of age and older. And then the Nicotrol inhaler, quantity limit of 3 inhalers per 31 days and age 10 years of age or older. That was a lot. That I think is one of the biggest classes we had to go through. So that concludes the CNS and others. Any questions or comments on that class?
Amanda, this is Chris. Not to put you on the spot, but with the opioid use disorder drugs like the buprenorphine products, are there any edits that apply when buprenorphine is being used with the myriad of other opioid type products concurrently?
There is, yes. So we have that across the opioid PA. It looks for the opioid product. So when an opioid comes in, when they're on buprenorphine, it's the opioid that's going to reject for PA and then require rationale for use and attestation and making sure that they've checked with the buprenorphine prescriber that that's the way they want to proceed.
Okay, very good. So that'll apply to all these other products that were just recently put onto as well.
Correct.
Good, thank you.
Any other questions? Sorry, Carol.
That's okay. I was going to check the same thing and then ask for a motion.
Start.
Do you have a second?
This is Chris, I second.
All right, we have a motion and a second. Dr. Ott.
Aye.
Dr. Klass.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
All right, thank you. We have all ayes, so that motion carries. On to the dermatologic classes. The Therapeutics Committee had no recommended changes in antipsoriatics. For the acne agents, we have several removals in the cleanup. So Azilex is no longer participating in the MDRP, so we're recommending removing that. And then Benzapro short contact and Benzeq wash, we're recommending removing because they are no longer manufactured in CMS terms. For the BP cream, BP pads, the RE wash and the SebPrev wash, we're recommending removing all of those as they are no longer manufactured in CMS terms. For the Prasian cleanser and the FC cleanser and the RA cream, also recommending removing all of those as they are no longer manufactured in CMS terms. And that concludes the dermatologic.
Any questions? Is there a motion to approve?
Move to approve, Dr. Marshall.
Second, Dr. Rao.
All right, we have a motion and a second. Dr. Ott,
Aye.
Dr. Class,
Aye.
Ms. Pippin,
Aye.
Dr. Marshall,
Aye.
Mr. Johnson,
Aye.
and Dr. Rao.
Aye.
I accidentally went out of order on there for you today. Throw you guys for a loop, maybe?
Just me.
All right. Sorry about that. And the endocrine classes with no recommended changes, the therapeutics committee has no recommended changes in these classes listed here. For the bone resorption inhibitors, they are recommending, so you'll see this throughout as we start moving through this a little bit more, so I just want to call this out now as I go through it multiple times. You may remember from our last meeting, we started updating the age limits for liquid products to being 12 years of age and under instead of 18. So you'll see us kind of making those updates into the other classes that we hadn't captured yet. So the alendronate 70 milligram per 75 mLs, maintaining its current status but updating its age limit to must be 5 years of age or older and less than 12 years of age or unable to swallow tablets. And then it's hydronate, removing from the SUPDLs, it is no longer manufactured and CMS termed. For the DPP4 inhibitors and combinations, saxagliptin moved to non-preferred and the saxagliptin metformin ER moved to non-preferred. For the GLP-1 receptor agonists and combinations, the Adlixin removed from the SUPDLs, it's no longer manufactured and CMS termed. And then for the Bydureon B-Size, Mounjaro, and Ribelsis, maintain its current status, but updating its initial and reauthorization PA criteria to include a trial and failure of at least 2 preferred agents for 90 days each, one of which is Ozempic or Trulicity or medical justification for use. And then on Byetta, Ozempic, Trulicity, and Victoza, the preferred agents, maintaining current status, but updating initial PA criteria to clarify the requirements for the metformin trial and failure. For growth hormones, for the somatropin agents, maintaining the current status, but updating the initial and reauth criteria for adult members or members with closed epiphyses with a prescriber attestation stating that they are continuing to monitor the member for intracranial tumor recurrence, progression of underlying disease, or malignant transformation of skin lesions if appropriate. And then we have a newer long-acting product, Ngenla, recommending adding to non-preferred with drug-specific PA criteria, an age limit of 3 years of age and older, and a trial and failure history of Skytrofa, which is another long-acting growth hormone. For Nutropin, recommending removing from the SUPDLs, it's no longer manufactured and CMS termed. Of note, the Nutropin AQ is still available. Sogroya, which is another long-acting product, maintaining its current status, updating its PA criteria to allow use in members 2.5 years of age and older, and then adding a trial and failure history of Skytrofa. And then Skytrofa, we would move to preferred and updating its step therapy to require trial and failure of one of the short-acting somatropin products. So you would have the short-acting, then you could step into Skytrofa, and then you could step into either Sogroya or Ngenla on the long-acting side. In the insulin's rapid acting, the therapeutics committee is recommending insulin aspart, all formulations move to preferred, and the Novolog, all formulations move to non-preferred. And then for the insulin's long acting, the insulin degludec flex and vials move to preferred with the step therapy of trial and failure of Lantus or Levemir for 90 of the past 120 days. And then the Tresiba Flex and Vials, which is the brand, would move to non-preferred and remove its step therapy. And then insulin glargine, just the Winthrop brand, would move to non-preferred. The other manufacturers are already non-preferred. For the miscellaneous oral anti-diabetic agents, as we talked about before with the solution for 12 years of age, so the metformin solution must be 10 years of age or older or less than 12 or unable to swallow the tablets. For the SGLT2 inhibitors and combinations, we now have an SGLT1 inhibitor. So we need to update our name so that we can include it in this class. So we're updating the name to just SGLT inhibitors and combinations. And then Brinzavi, we are recommending adding to non-preferred. And then NPFA adding to non-preferred. For the testosterones, the Androgel 1.62% metered pump is no longer participating in the MDRP, so we're recommending removing that from the SUPDL. And then same thing with Kaisertrex. So that has actually already been removed from the PDL, but it is no longer participating in the MDRP either. We wanted to add some quantity limits to the oral agents that currently don't have quantity limits in place. So Jatenzo maintaining its current status in PA criteria, but adding quantity limits on the 158 milligram strength of 2 capsules per day, the 198 milligram strength 4 capsules per day, and on the 237 milligram strength 2 capsules per day. For the method test, maintaining its current status in PA criteria, and then having the breast cancer indication have a quantity limit of 50 capsules or tablets per day, and then all other indications would be at 5 capsules or tablets per day. Oxandrin is no longer an FDA approved drug, so we're removing that from the SUPDL. And then T-Lando maintaining its current status and adding a quantity limit of 4 capsules per day. And then lastly, for the preferred injectable and topical testosterone agents, updating its reauthorization criteria to include history of injectable or topical testosterone for at least 90 of the past 120. And this is just to allow people to switch between the two more easily as having therapy before. So if you were on injectable therapy prior and you're coming into reauthorization, but you want to switch to the topical therapy, you should be able to do that, and vice versa. If you were on topical therapy and need to switch for whatever reason to the injectable, you could do that through the reauthorization criteria. The Therapeutics Committee is recommending adding a new drug class to the endocrine group, urea cycle disorders or hyperammonia treatments. And so we have several products here. Bufenil powder and tablets would be added to preferred and the preferred brand drug list with drug-specific PA criteria. Carbaglu would also be added to preferred, maintaining its brand preference. It's already on the brand preferred list, and drug-specific PA criteria. Feburain would be added to preferred with drug-specific PA criteria. And then carglumic acid, Alpruva packets, Ravicti, and the sodium phenylbutyrate powder and tablets would all be added to non-preferred with drug-specific PA criteria. And that concludes the endocrine classes. Any questions?
Yeah, Amanda, I have a question. On the androgel, I just want to make sure I've got the right. Can you go back to that slide? Because it is still a preferred agent in the public facing PA criteria that we got. Is that right?
It shouldn't be. If it is, we'll make sure we remove it.
Okay.
Because it's no longer, we can't do anything about it, unfortunately. It's no longer participating.
Okay, no, I understand that. I just wanted to understand because I saw that there, and then in the preferred agents, it's listed on page 2 of the public facing PA document as the first drug on the bottom of page 2.
I think you're right. We need to remove that.
We'll make sure we remove it before we post that.
Okay, but the generic is still preferred, right?
Yes.
Okay, got it. Thank you.
Thank you.
Hey, Amanda, this is Chris. Can you remind me what the silent auth criteria is on the GLP-1s?
Looking for indications.
Yeah, it's looking for indication, and then now we're also looking for history of use.
History of use. Yeah.
That would be the new criteria.
Let's for metformin look back as well
if they don't have a certain indication, yeah.
So the indications include just the FDA approved indications, or are there others?
It's FDA approved and approved compendia.
Excluding weight.
Yeah, excluding weight loss, which technically those agents aren't FDA approved for weight loss. That's the other.
Right. Okay.
Any other questions?
Is there a motion to approve?
This is Chris. I motion to approve the endocrines.
Second, Dr. Marshall.
All right, we have a motion and a second. Dr. Ott.
Aye.
Dr. Klass.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
Thank you. All approved, so that motion will carry. Onto the estrogen and related agents. In the estrogen and related agents class, there's a new product, Bioza, for hot flashes in menopausal women. We're recommending adding to non-preferred with drug-specific PA criteria, adding an age limit of 18 years of age and older, and a quantity limit of 1 tablet per day. In the contraceptives, they are recommending that Twerla be maintained as preferred, as well as Xulane, and then Zapamine move to non-preferred. And that concludes the estrogen and related agents.
Are there any questions? Is there a motion to approve?
Move to approve, Dr. Marshall.
All right, we have a motion and a second. Dr. Ott.
Aye.
Dr. Klaas.
Aye.
Ms. Pippin.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
Thank you. All ayes, so that motion will carry. In the gastrointestinal agents recommendations, there are no recommended changes in the classes listed here. For the anti-ulcer agents, the Therapeutics Committee is recommending that the Carafate suspension maintain its current status, but updating its age limit step therapy to say must be 1 year of age or older or less than 12 or unable to swallow the tablets. We've got several age limits for solutions in this group. In the famotidine oral suspension in the H2 receptor antagonist, maintaining its current status, but updating its age limit to must be under 12 years of age or unable to swallow the tablets. For the laxatives and cathartics, they are recommending that Relistor injection be added to preferred, with step therapy requiring trial of lactulose, sorbitol, or polyethylene glycol, and a diagnosis of opioid-induced constipation. So just capturing the injectable product, we historically had the Relistor tablets captured. And the proton pump inhibitors, the esomeprazole strontium is no longer manufactured in CMS terms, so recommending removing that from the SUPDL. And the rabeprazole sprinkle capsules are no longer participating in the MDRP, so we're removing that from the SUPDL. And that concludes the GI agents.
Is there a motion to approve?
Move to approve, Dr. Marshall.
Last second.
All right, we have a motion and a second. Dr. Ott.
Aye.
Dr. Klaas.
Aye.
Ms. Pippin. Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
All right, we have all ayes, so that motion will carry. Moving on to the genital urinary agents, the Therapeutics Committee has no recommended changes in BPH. And then for the urinary tract antispasmodic anti-incontinence agents, the Therapeutics Committee is recommending that the Myrbetriq granules maintain its current status and updating its age limit step therapy around must be 3 years of age or older or less than 12 years of age or unable to swallow the tablets. For the Vesicare LS, maintaining its current status and updating its step therapy to must be 2 years of age and older and less than 12 years of age or unable to swallow the tablets. And that concludes the genital urinary class.
Is there a motion to approve?
Move to approve, Dr. Marshall.
Last second.
All right, we have a motion and a second. Dr. Ott.
Aye.
Dr. Klaas. I saw that, so I'm going to count it. Ms. Pippin.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
All right, so we have all ayes, so that motion will carry. In the hematologic agents, the Therapeutics Committee has no recommended changes in the platelet aggregation inhibitors. For the direct oral anticoagulants, the Xarelto suspension maintaining its current status and updating its step therapy to must be under 12 years of age or unable to swallow the tablets. And for the hematinics, there's a new product, Jesduvroc, that they are recommending adding to non-preferred with drug-specific PA criteria with an age limit of 18 years of age or older, and then quantity limit max dose of 24 milligrams per day, and then 1 tablet per day for the 1, 2, and 4 milligram strength, 2 tablets per day of the 6 milligram strength, and then 3 tablets per day of the 8 milligram strength. And then Reblozyl maintaining its current status, updating its drug-specific PA criteria to remove previous erythropoiesis stimulating agents, step therapy requirement for myelodysplastic syndrome indication, and then adding continuation of therapy criteria. Out of all the words in that previous was the one that apparently hung me up. Checking it out. In the leukocyte stimulants, they are recommending that Fulphila move to non-preferred, and then Nivepria move to preferred. So we'll still have a preferred agent there. There is still some supply issues with Philnetra that we're trying to keep track of. So we want to make sure we have 2 agents there. And then Neupogen would move to preferred, and then the Nivastem would move to non-preferred. So flipping those agents there. And that concludes the hematologic agents.
Is there a motion to approve?
Dr. Marshall, move to approve.
I think I saw Dr. Class too. Yeah, okay. We have a motion and a second. Dr. Ott.
Aye.
Dr. Class.
Aye.
Ms. Pippin.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
All right, we have all ayes, so that motion will carry. We're coming up on the home stretch here in the Therapeutics Committee recommendation. So in the topical agents classes, these classes had no recommended changes by the Therapeutics Committee. For the dry eye disease class, their Isuvis maintaining its current status but updating its quantity limit to have quantity does not exceed 2 bottles for a maximum of 14 days at a time and limited to 1 fill every 90 days. And then Mibo adding to non-preferred and adding drug-specific PA criteria with a quantity limit of 4 bottles per 30 days. For the miotics intraocular pressure reducers, Iuza, which is a latanoprost product, and it's a preservative-free latanoprost product, adding to non-preferred with step therapy that they must have trialed and failed the latanoprost or prescriber has provided valid medical justification for use of Iuza over the regular latanoprost. For the topical antiparasitics, the Natrova is going to move to preferred, maintaining its current quantity limit, and then the Spinosad will move to non-preferred and maintaining its current quantity limit. In the topical immunomodulators, for Zor-Eve, maintaining its current status and current trial and failure history, but updating its age limit to allow for use in 6 years of age and older. And that concludes the topical agents.
Is there a motion to approve?
Yes.
I think Dr. Class moved to approve. Is there a second?
Second, Dr. Rao.
All right, we have a motion and a second. Dr. Ott.
Aye.
Dr. Class.
Aye.
Ms. Pippin.
Aye.
Mr. Johnson.
Sorry, I had to find my mute. Aye.
Dr. Marshall.
Aye.
And just want to check, Dr. Marshall, are you okay? Do you need the Heimlich? Do we need to call somebody? You good?
Aye.
And Dr. Rao.
Aye.
Perfect, thank you. So the last class we had for review was the adalimumab or Humira and its biosimilars. We did an off-cycle review, you might remember, because several of the biosimilars were new. They didn't have their pricing strategies out yet, so we wanted to review them kind of as a group together in this space. And so after that review, the Therapeutics Committee is recommending that the adalimumab Mylan brand move to preferred and preferred Silenoth PA criteria, as well as Hadlima moving to preferred and the preferred Silenoth criteria. Humira will still also be preferred, so you will have all 3 available as preferred. And that is it for that off-cycle review.
Is there a motion to approve?
Dr. Marshall.
Amanda, I think Dr. Marshall approved and Dr. Class seconded.
Okay, I couldn't tell if that was Mr. Johnson or Dr. Class. Either way, we've got a second, so we'll move. Dr. Opp,
Aye.
Dr. Class,
Aye.
Ms. Fippen,
Aye.
Mr. Johnson,
Aye.
Dr. Marshall,
Aye.
and Dr. Rao.
Aye.
All right, thank you very much. That concludes our therapeutics committee review. We now have our annual review of the OTC drug supplement and contraception formularies. So there's kind of a lot here, but I'll try and simplify it as much as possible. So on the OTC drug formulary, we have several products that we're removing because they're no longer participating in the MDRP. So you can see that list there. And then the loperamide liquid is inactive or unavailable. And this may seem like a lot of products, but in some cases we have other percentages or other strengths that are available, and you have that kind of in your listing. And then we're recommending adding the following products to the formulary. So the cetirizine pseudoephedrine 5/120 ER, the fexofenadine 30/5 suspension, miconazole nitrate 200 milligram vaginal suppositories, the psyllium 52.3% powder, simethicone 82 tablets, and simethicone 180 milligram capsules. And then you'll notice when you look at your grouping, there's a lot of updated age and quantity limits that we placed throughout. They were highlighted in the document that was sent over. We just didn't want to bog down the PowerPoint with listing every single one there, but you do have them listed in your document where the age is updated. So in a lot of cases where it was the age 18 and under, it changed to 12. So you may notice that. And then in the OTC supplements formulary, calcium carbonate, the 1250/5 suspension that was not considered a drug is no longer available, but we do still have a product for that on the OTC drug formulary, which may be confusing because one's a drug and one's not. And then as far as adding products, adding magnesium carbonate, 54 milligram per 5 ml, and then the pyridoxine 25 milligram tablet. And then again, we updated some age and quantity limits throughout. And then on the OTC contraception formulary, there is an inactive unavailable minoxidil 9, 12.5% foam that we're recommending removing. And that is all for the OTC supplements and contraceptives formulary. Any questions or comments on those?
This is Petra. I have a question about, we cover DocuState and Senna separately, but we don't cover the combination product. Is there a reasoning for that, and could we add the combination product?
It's cost related. So we review the cost of the products on the formulary. So the reason that it's currently not in there as the combo product is cost. It's much cheaper to have the separate agents.
Maybe we can talk about that offline, because you're now 2 dispensing fees might be worth another.
That's fair. We'll we'll take that back and review it with OMPP, and if they decide they want to add it, then we can look at adding it.
I don't want to give the implication that we have offline meetings, because that's kind of illegal, but if you have, no, I'm just being funny, but if you have something that you want us to look at specifically, Amanda could take that back and we could talk about it, and then maybe
Bring it back. Yeah, we could always bring it back.
Yeah.
Okay.
You were looking at the DocuState Visicodal, right, Petra?
No, DocuState and Senna.
DocuState and something. Okay.
Yeah, I just work in a practice now where we have a lot of antipsychotic agent use and constipation prevention issues, and that seems to be the preferred product. So we have a lot of patients where it's not covered.
All right, we'll take a look at that and bring it back, and if it's something that we feel like we can add, either way, we'll let you know what the decision was at the next meeting.
Okay, thank you.
Mm-hmm.
Are there any other questions? Is there a motion to approve?
Move to approve, Dr. Marshall.
Dr. Class.
All right, we have a motion and a second. So Dr. Ott,
Aye.
Dr. Class,
Aye.
Ms. Pippin,
Aye.
Mr. Johnson,
Aye.
Dr. Marshall,
Aye.
and Dr. Rao.
Aye.
All right, that motion will carry. Thank you. Yes. I can. All right, so next up, thank you all for bearing through that. I know that was a lot to go through. Next up, I don't believe, well, let me first capture any updates from managed care today. I know we don't have any slides, but any updates or comments in your group that you need? Okay. All right, I will turn it over then to Ms. Lugo, who is going to do the review of the managed care prescription drug programs.
Hi, everybody. It's that time of year again. Just as a reminder, we have 3 statutorily required reports. The PDL report, the DUR annual CMS report, and this little guy that we affectionately refer to as the side-by-side report. So this is a comparison of the managed care organization's benefit to one another and to fee-for-service. So we have to look at the analysis of the single source drugs requiring PA, including how many in each plan, the types of drugs subject to a restriction, rationale for prior authorization, and prior authorization statistics and grievances, pharmacy-related grievance data within a 12-month period. Next. So this is calendar year 2022 captured in this report. This is enrollment, total enrollment for 2022. As we know, the pandemic was at its peak at this point. We were not disenrolling members at all at this point. We got to a high in April of 2023 of about 2.3 million, and we're down to about 2 million at this time. But enrollment was high in 2022. And you can see the breakdown of where the majority of members sit. And Anthem definitely has the majority of the members in Indiana. Next. And this is just another vision, just a pie graph showing you where the distribution of members are. And again, fee-for-service will shrink in midsummer as we transition a lot of our dual eligibles and some other folks to the Pathways program, which is also a managed care program. So Anthem and United and Humana will be receiving either new members or additional members at that time. So what we did, because we implemented this SUPDL, the majority of this statute really doesn't apply. So we did our best to try to make it relevant in light of the single PDL. So what we did is we looked at neutral drugs. So again, neutral drugs are drugs that don't sit on the preferred drug list in any way. So they're not preferred, they're not non-preferred, they're just not mentioned. And managed care is able to manage those as they see fit. They send their criteria to OMPP. So the neutral drugs, we were submitted files from each MCE and fee-for-service listing their drug file, their neutral drug file. You can see the numbers there. They're pretty consistent. MDY's always is a little high because of the way their drug file works. They have an NDC for each and every strength package size for a specific drug, and that's why theirs is always significantly higher than everybody else's. PA, you can see that here, step therapy, age limits, and quantity limits are all fairly consistent. Fee-for-service actually has a decent amount of quantity and age limits, more so than most of the MCEs do at this time. I did send you out also a spreadsheet that itemizes per MCE the drugs that sit on the neutral list. So if you want to know who has what drugs in their drug file, you can reference that. Next. This is a little busy, but this is the prior authorization percentage per quarter. We have a dashboard that we monitor this on now at OMPP. Again, to make a statement about whether or not a prior authorization percentage is high, if that's a good thing or a bad thing, I think you have to take into account the specific drug class that you're looking at. So, but in general, they tend to be in the same ballpark with a few exceptions. And again, remember, United was new to the program, so they're going to look a little strange. Okay. Grievances, these are reported to the office quarterly, and this makes sense with what we've seen. Anthem has clearly the most pharmacy grievances. However, they also have the majority of members. We do also track timely completion of these 48 hours. They need to have these turned around. And if they don't do that, we ask them for explanations on that. So this is something we monitor pretty closely. This is just going to divide these up by plans. So MDWise is not in Hoosier HealthWise, so that's why you're seeing in Hoosier Care Connect. We also submitted to you a zip file of all the CAPS reports if you're interested. Again, those are very unrelated in general to the pharmacy program. There's some questions on there about flu shots and tobacco cessation counseling. But this kind of goes over again what you're looking at. They submit adult and child ones, and they submit different ones for different programs, and they identify areas for improvement. So again, I don't find these particularly insightful in terms of the pharmacy benefit, but in general, you can see what the overall satisfaction is for some of the plans. So those are in your zip file. I think that's the last, and that's the last slide. Any questions on the side-by-side? Great, thank you.
Thank you. All right, we will move on then to new drugs. We do have a few here that we're wanting to capture. So creation of a corticotropin PA. And so this PA is, they must meet one of the following. So they're either less than 2 years of age and have a diagnosis of epileptic spasms, or they're 2 years of age and older, and then they have a diagnosis of acute exacerbation of ankylosing spondylitis, acute exacerbation of psoriatic arthritis, acute exacerbation of rheumatoid arthritis, nephrotic syndrome, or lupus nephritis, severe acute and or chronic allergic inflammatory disorder involving the eye, severe erythema multiforme, and then Stevens-Johnson syndrome, symptomatic sarcoidosis, symptomatic dermatomyositis, systematic lupus or erythematosus, or a transfusion reaction due to serum protein reaction, or they're 18 years of age and older and have a diagnosis of acute MS exacerbation, and they've trialed and failed IV or oral corticosteroids as confirmed by claims history chart documentation or provider attestation. And then, or they have a diagnosis of acute gout attack and they've trialed and failed colchicine, NSAIDs, or glucocorticoids as confirmed by chart documentation or claims history. And then the next new product is Lycomez, which is a metronidazole suspension. And we're recommending that the member is under 12 years of age, or they're 12 years of age and older and unable to swallow the capsule tablet formulation of the metronidazole. And that concludes the new drugs. Any questions or comments there? All right, if I could get a motion in a second, please.
Dr. Marshall moves to approve.
Dr. Rao, second.
All right, thank you. So we have a motion and a second. Dr. Ott.
Aye.
Dr. Klaas. Ms. Pippin.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
And Dr. Rao.
Aye.
All right, We have all ayes, so that motion will carry. Thank you. Any liaisons with other boards today? All right, I'm hearing none there. I know we have public comment. I'm going to start with in the room since they came in today. So in the room, I have John Landis from Brayburn for Briggs Addy.
Hi, everyone. Thank you all for your time. Yep.
Sorry, I'm just real quickly moving my timer over for you. All right, go ahead.
Awesome. Thank you. So thanks all for your time. My name is John Landis. I'm a pharmacist, a part of Brayburn Medical Affairs. Appreciate the opportunity today to speak about Brixadi for the treatment of opioid use disorder. In 2017, the U.S. declared the opioid crisis a public health emergency. And in that year, there were over 40,000 deaths due to opioid overdose. Fast forward to today, the opioid crisis remains the only remaining national public health emergency. And just last year, there were over 80,000 deaths due to opioid overdoses. That's double the number of opioid overdoses since that public health emergency was declared. Clearly, there's a need for more accessible treatment options. And today I'm going to speak about Brixadi, which is a long-acting subcutaneous injectable form of buprenorphine that was approved just this past May. It's unique in that it's available in both a weekly and a monthly injection provided by a healthcare professional only. This was intended to meet the patient where they're at, provide them with another treatment option to both help initiate and sustain long-term recovery. Brixadi is indicated for patients both new to treatment as well as those using oral buprenorphine. The way that it works is via a fluid crystal technology. This technology allows for a small volume to be injected into the subcutaneous space of the skin. It forms a gel that's nearly unpalpable and allows for the steady release of buprenorphine. Brixadi is the only long-acting injectable that was studied head-to-head with the current standard of care, sublingual buprenorphine, in a randomized controlled trial. When compared to sublingual buprenorphine, it demonstrated significant reductions in opioid use. Furthermore, in a phase 3 trial that lasted 24 weeks, included over 400 patients, 25% of which were exposed to fentanyl, they found no overdoses occurred in the Brixadi group and 5 in the sublingual group. Adverse drug events reported were injection site reactions, headache, nausea, and constipation, all of which were mild to moderate in nature. In closing, I'd like to advocate for the addition of Brixadi to preferred status on formulary as soon as administratively possible. Thanks, guys. Open to any questions that you guys have.
Any questions? Sorry, let me make this stop first real quick. All right, thank you. So we normally only allow 2 speakers per drug for public comment. I have 2 different individuals in the chat box, so I'm gonna start with the first one that's there, and if she's still there, then I'll let her provide public comment, and then if she's not, then I'll go on to the second one. So I have first in the chat, Christy. Christy, are you still on? I don't see her right now, so I'm going to go to the other person in the public comment for the chat box, which is Chantel Allen. Chantel, are you on? They may both not be on anymore. Trying to do a quick check just to make sure I'm not cutting anybody off that's not able to get off mute, but I don't see them. All right, I don't see either of them. So
I do want to remind industry too, our public speaker comment is that you are only supposed to be presenting new product information, which is changes since the last review or new products. We've been super lax on that, but I want to remind folks of that. We're going to be enforcing that, so please 2 speakers per manufacturer or labeler, and you need to limit your speech to changes since the last review or new products.
All right, I did do a check. I don't see either of them online. Any other public comment that we haven't captured? You can either shoot a message in the chat box, raise your hand, stand up in the meeting. All right. I'm hearing and seeing none, so we will go ahead then and proceed to old business. Any old business? All right. Hearing and seeing none. Any new business before I go into our new business?
Hey, Amanda, this is Chris. Just after we've gone through all the formulary changes, I just wanted to understand a little bit. Some of the changes were removing some of the generics from preferred and putting on the brand products like Neupogen and what's the parasitic Natroba. Are there any concerns with access on those and whether or not they're available right now in retail pharmacies for those supplies?
So we do check everything before we move it across by checking wholesalers. We reach out. We have some folks that we can check out to. We also have a shortages list that we'll check before we move a product over, because it's not just it's obviously an access issue for patients and an issue for pharmacies, but it's also then an issue for us that when we've got to change things over. So we like to be really secure in knowing that a product is available. So you might have noticed in the one product where we, I think it was the Nivepria Filnetra group, where we still are keeping another agent over there in preferred because of a manufacturing issue or not having enough stock. So we do try and keep track of that pretty closely. That's not to say something that's on our brand preferred list doesn't eventually wane over time and we haven't captured it, but we also will take comments from the call center or anything that's coming up there and make movements if we need to as well. But when we make a movement and place something, we validate with the manufacturer, with wholesalers, that there's plenty of stock and that they don't anticipate any stock issues. Does that help?
Yeah. I just found myself in a CVS a couple days ago and happened to be standing and waiting in front of some of the topical anesthetics, and I saw the Spinosad, but I didn't see the Natroba, so I just was curious when that came up, kind of jogged a memory.
Okay. Any other new business before I go into mine? All right. So we do have a few updates here. So for the non-SUPDL PA and step therapy criteria, you'll notice there's some clarification on the look back for history of use for agents throughout the PA. On Abrivsvo, updating the criteria to member is between 32 and 36 weeks gestation during the months of September through January. So updating that criteria based on the current guidance. For Ermezo, tyrosine solution or tyrosine sol, and thiquidity, which is a levothyroxine solution, updating the age criteria that the member is under 12 years of age or unable to swallow the capsule tablet formulation. For Zatmep, which is a methotrexate product, updating its age criteria for initial authorization and reauth to the under 12 years of age or unable to swallow the capsule tablet formulation. For some SUPDL updates, so the Flovent HFA and Discus is kind of on its way out, and so there probably are some pharmacies that may still have one if they're lucky, but it's on its way out. So we're moving that to non-preferred, and then moving the fluticasone HFA and the fluticasone Discus to preferred to make sure we can capture those patients that need that product. On the targeted immunomodulator PA for the adalimumab, ADAS, the adalimumab FKJP, the Julio, the Hiramaz, and the Usemri, adding the non-infectious uveitis indication to those products as they have that, and then Adakio adding the hidradenitis suppurativa indication to their approval criteria. And then for our preferred brand drug list, something that we were just talking about, we do have some new products that we're moving over to there. So Livalo adding to the list, Mydayis adding to the list, but then maintaining its generic as preferred until 1/1, just because there are so many stimulant shortages. We just want to make sure that we're capturing that. So kind of, Chris, to your point, that's an area where we like to make sure we've got enough product available. And then Votrient adding to the list. And that concludes our new business. Any questions or comments?
So Amanda, Dr. Rao, is that 1123 or 1124?
That actually should be 1124. I like to be a year behind. That's how I like to roll. We're just keeping you on your toes. I appreciate it, Dr. Rao. So yeah, 1124. And even at that point, we'll probably still assess and make sure that there's no concerns at that point when we make that movement.
I took my Deus this morning.
All right. If there are no other questions, if we could have a motion and a second, please.
Dr. Marshall, move to approve.
Chris Johnson seconds.
All right. We have a motion and a second. So Dr. Ott,
Aye.
Dr. Klass,
Aye.
Ms. Pippin,
Aye.
Mr. Johnson,
Aye.
Dr. Marshall,
Aye.
and Dr. Rao.
Aye.
All right, we have all ayes, so that motion carries. Any other new business or anything we need to discuss today before I turn it over to Dr. Ott for the last item on the agenda? All right, well, Dr. Ott, that takes us to adjournment. I appreciate everybody bearing with such a long meeting and appreciate you all being here so that we could get all of this business done.
Really good job moving us through it. Thanks. So we'll adjourn this meeting. Happy Thanksgiving, everybody.
You too.
Yes, happy Thanksgiving. Have a great weekend. Thank you. Bye-bye.